the moment we have all been waiting for. It's time to don our glasses for the 3D live surgery with legends at work. First, we have Dr. D. Ramamurthy, the chairman of the Eye Foundation Group of Hospitals. Doctor will be operating the left eye. The intraocular pressure was 18 mm mercury. The best corrected visual acuity was 612 with 2.25 dioptosphere with 0.75 at 180 degrees. The patient did not have any systemic history or illnesses. And these are the scan findings. The lens we'll be using today will be left eye 24 diopter Hoya geometric toric at 137 degrees. Over to the OT.
Very good morning, everyone. Am I heard clearly?
Yes, yes.
Light node, light node. Very good. Basically, I think the patient has already been introduced, and I'm going to be operating on the left eye of the patient using a geometric plus and saline on the cornea. I'm doing under topical anesthesia. I'm seated temporally. Light node. Very good. Introducing a little bit of phenocane. I like to make these incisions little limble, and I always like to see that blood, because that tells me that this incision is going to heal better. I want the 2.4. Yeah, exactly. Helps me to identify the site also as more Sri Stele. And earlier I always used to make a 2.2 millimeter incision. Last 2-3 years I have shifted over to 2.4. I find that though the Hoya geometric will comfortably go through even a 2 millimeter incision, but whether the introduction of the intraocular lens, the cartridges, everything I find works much better with no disruption of the wound architecture when I make a 2.4 millimeter incision. This is HPMC? Yes, sir. I'm going to be using plain HPMC right now for this patient. Has a slightly low endothelial cell count in the range of about 2100. So we will be protecting the endothelium with Viscoat, chondroitin sulfate, but that will come later. Can I have a Sinski hook? Must be a corneal marker if you have one. Yeah. And I like to use this when I'm not using a digital overlay. I like to use this marker for my capsular rhexis. It's about 5 millimeter in size. It corresponds to about 5 millimeter, 5.5 millimeter on the lens surface. And this is the start of the capsular rhexis. I tend to go through my side port, and I want to make sure that there's a good overlap of the rhexis margin on any trifocal toric lens, especially a high-end lens like geometric toric. So having the rhexis well centered on the Purkinje image. No, don't put. I mean, it's important you instruct your assistant not to put saline at this stage, because then that impression that I have created would disappear. I am doing it slowly, but I strongly believe that time spent on getting a good rhexis in these cases is time well spent. And that's the completion of the rhexis. I am quite happy with that. I am going to do hydro, light node, light node. Very good. It's a fairly soft cataract, and that's quite healthy. Can I have the Sinski hook? I saw the lens moving forward. I could see the fluid wave also. And nowadays I always rotate these lenses quite significantly, irrespective of the grade of cataract. I find that not only breaks up the corticocapsular adhesions, but also that facilitates removal of the cortex very easily. And always spin it around 2-3 times as I'm doing now. Can have the Sinski. It's a very soft cataract, so I'm not sure whether I'm going to be able to chop it. I just do a phaco flip or just suck the whole lens out. And I'm using a Centurion machine with a IOP of 30, which translates to a bottle height of 41. That's my standard settings, pre-phaco. Chopper. Sculpt. I always, can we improve the red reflex? I always create a small trench with respect to the grade of cataract, chop. I don't think this is choppable. Sculpt. These softer cataracts I prefer a stop and chop. Gives me much better control because viscoat. Now is the time I am going to use viscoat to protect the endothelium. Viscoat. And this is a slightly modified soft shell technique of my own, where you can see this viscoat is going up and protecting the endothelium. Let me have some viscoat. And I don't want to do the phaco in a sea of viscoat because that's thermogenic, and this is the only situation you get a wound burn. So I'm going to put a lake of visco in the center. Can I have 2 Sinskey hooks? Saline on the cornea. No Sinskey hook. My normal technique is a phaco chop, but this cataract seems to be extremely soft, not amenable to chopping. So I've created a deep trench, and essentially any grade of cataract, the idea is to break the backbone of the nucleus by whatever way you achieve it. Yeah. No, saline. Saline. You can see the extremely soft cataract. She had a surgery done in the other eye only 2 days back, and with excellent visual outcome. She has received a geometric in the other eye also. It's a good idea sometimes to combine a geometric and a geometric plus, and I think with these combination you get excellent vision for the entire range from distance, near and intermediate. But studies have shown that irrespective of whether you put geometric plus in the one eye or geometric in both eyes, the spectacle independence is very good. And I myself, what I do is to put and it's not really important to determine whether it's a dominant or a non-dominant eye. Basically what I do is to the eye with a greater amount of cataract, I put a geometric lens, then 1 week later assess the patient as far as the quantity of vision is concerned, not just what my optometrist writes, but what the patient says, their comfort level. Based upon that, I decide whether to put a geometric plus or geometric in the other eye. But any of these combinations seem to work well. I think this is only lens which works on the principle of light distribution. Both the geometric as well as the geometric plus are trifocal lenses, having a 3.5 plus ad and a 1.75 plus ad. Rings are 8 in number, distributed right in the central 3.2 millimeters, and because of the peripheral 2.8 is essentially refractive, because of which the amount of dysphotopsia, not being extending onto the entire optics of the lens, not a full optic diffractive rings, also adds to the lesser amount of dysphotopsia these patients experience. And I always use a bimanual IA, as you can see, saline on the cornea. I think all the advantages that we have come familiar with the Webinex platform is there. Little sticky cortex, taking a little time to come, but I'm sure it will. You can see that small blob of chondroitin sulfate viscode that is there right next to the endothelium. That tells me that there is good endothelial protection. And these Webinex lenses, the entire platform, including the geometric, goes through even a sub 2 millimeter incision. And we are all familiar with the posterior. I'm just polishing the posterior capsule. Quite happy with this, good rexes. Saline. I always do a bit of hydro polishing where I just pass you can see all of those fibers coming off, and I don't polish the rim of the anterior capsule unless it's a very small rexus or there is pseudo exfoliation or pediatric cataract or case of uveitis where there is tendency for capsular phimosis. What is this? Visco. No, I'm going to do hydro implantation. Can I have the lens? Prepare the lens and give me. So I generally prefer to do a hydro implantation of these lenses, any lens for that matter. And the fact that this lens, you put the visco also. So the fact that this lens comes with both, you have a choice of, let me just show this. It's called multi-cert simply because you have this 6 millimeter protrusion and you have this shield which can be moved forward. If you have this 6 millimeter tip of the cartridge that's exposed, you can introduce it into the anterior chamber and it can be injected almost right into the capsular rexus, into the capsular bag. You also have a small slit here. Many of you might have noticed when you implant the conventional lenses, if it's a high diopter lens, very thick lens, sometimes the cartridge gives way. Can I have a Sinskey hook? So the idea of this, having this teardrop split over here is so that it gives more space for the lens, to optics of the lens to pass through without disrupting the cartridge. And this is a slider, and I am not going to move it forward, but just in case you want to keep it at the mouth, then you could easily move this forward, which will reduce the 6 millimeter by half to about 3 millimeters. And basically, my assistant, who is doing a great job, has already introduced the viscoelastic. And the reason it's called a multi-cert is, depending upon your comfort level, you can either use a screwing motion to move the lens forward, or you can use a plunger to move it, move the lens forward. Since I'm going to be using a hydro implantation, I prefer doing I'm going to use the plunger. Can you increase the intraocular pressure to 60? Yeah. So this is the only place I increase my intraocular pressure because I want a deep anterior chamber. ಆಯ್ತು ಮಾ
ಆರಾಮಾಗಿರೋ ಲೈಟ್ ನೋಡಿ. ಆಯ್ತು ಆಯ್ತು.
I would have preferred a little better control, but it's okay. Yeah. Can I have the aspiration cannula? Because of that air bubble, I just want to remove that. You can see that central 3.2 millimeters. Light noduma, light nodu.
ಲೈಟ್ ನೋಡಿಮ್ಮ. ಆರಾಮಾಗಿರಿ. ಆಯ್ತು.
You can see geometric toric. ಆಯ್ತು ಮಾ. ಇನ್ನೇನ?
ಲೈಟ್ ನೋಡಿ. ಕಣ್ಣು ಅಲ್ಲಾಡಿಸ್ಬಾರ್ದು.
ಇನ್ನಮ್ಮ ನೋ.
ಹಂಗೆ ರೀ.
I put drops. I put intracameral also.
ಆರಾಮಾಗಿರಿ, ಚೆನ್ನಾಗಾಗ್ತದೆ. 5 ನಿಮಿಷ ರೀ. ಆಯ್ತು.
And it's very unusual for a patient to have this amount of discomfort. Can I have the calisto, please? ಆಯ್ತಮ್ಮ.
ಎಲ್ಲ ಮಾಡಬಾರ್ದಮ್ಮ, ಆರಾಮಾಗಿರಿ. ಅಮ್ಮ ಆ ಥರ ಅಲ್ಲಾಡ್ಸ್ಬಾರ್ದು. ಏನಾಗ್ತಾ ಇದೆ? ಆರಾಮಾಗಿರಿ. ಆಯ್ತು ಆಯ್ತು ಆಯ್ತು.
Some of the patient is very uncomfortable, though I don't see really the reason. The calisto doesn't show up on the eyepiece. No, dialing hook. I'm more used to the Varion. So
ಆರಾಮಾಗಿರಿ. 5 ನಿಮಿಷ ಆಗೋಯ್ತು. ಅಲ್ಲಾಡಿಸ್ಬಾರ್ದು. ಆರಾಮಾಗಿರಿ.
saline. I'm slightly unfamiliar with this viewing through the Is it okay? Saline. I have a good rhexis overlap, and I think it's just a T2 lens that we have used. That's another important point. In these cases, in these any trifocal or multifocal, even small amounts of astigmatism needs to be taken care of. And if you leave astigmatism uncorrected, then the multifocality effect is lost. Quality of vision is also not that great. There's a little bit of hyphema, but I think that's going to absorb. Patient is not very comfortable, and
I wanted to ask you a question.
yeah.
I do believe that we have to be very versatile, whether we chop or stop and chop based on the kind of cataract. But in some soft cataracts, don't you think it makes sense to do a hydrodelineation and a hydro, because that sort of separates the epinucleus from the endonucleus, and you can just get the endonucleus out and then do a viscodissection and get the epinucleus out? Or do you ever use a flip mode also for these very soft cataracts, or you prefer to do a stop and chop in all of
No,
them?
I completely agree with you, Chitra, in the sense that there is there are several ways of flipping the, skinning the cat. In case when it was so soft that when I did the hydro, if the entire lens nucleus had collapsed into the anterior chamber, I would have gone ahead and done a flip mode. But in this sense, it was inside. I did create a small I did create a small trench, and I tried to chop, but then found that the nucleus was too soft. It was not choppable, so I just extended the trench and split the nucleus. It was essentially stop and chop is what I did,
Yes.
and then subsequently implanted the lens.
Yes.
Not so happy with the positioning of the lens. Can I?
The other thing also is, I think for the audience sake,
Selling.
hydroimplantation is one very easy way, because especially in toric IOLs, there's one step of evacuation of the viscoelastic is, you can miss it. But in this kind of very uncooperative patient, and if you're on a learning curve, better to use viscoelastic, which will push the PC back. That is one important thing. And the other important tip which he had to tell us was you need to increase the intraocular pressure when you are going to be doing a hydroimplantation, IOP on the machine, and then bring it down once the IOL is in the capsule bag. One last question, Dr. Ramamurthy. You did tell us about your geometric lens placement and all that, but in which percentage of your patients do you need to use geometrics in one eye and geometric plus in one eye, or is it that in majority it's geometric plus only? Like what is your thought process?
Basically what I do is to, I don't really care about dominant, non-dominant eye. The eye which most often we counsel the patient for bilateral surgery, and whichever eye has greater amount of cataract, we operate on that first. Usually the lens we implant is a geometric lens. And then 1 week later, we reassess the patient, not just what the optometrist has written in the case sheet, but also what the actual experience of the patient in reading, intermediate vision, distance, etc. The patient says he or she is very comfortable with the lens that was implanted. Near vision is also working well. We'll just go ahead and implant a geometric in the other eye. And in case the patient says the near vision is somewhat inadequate, we go ahead and implant a geometric plus in the second eye. Having said that, studies have revealed that with bilateral geometric implantation, geometric plus implantation, as well as this combination, majority of these patients are spectacally independent. And usually, I can't tell you the exact numbers, but I would say that about 50% of patients receive a combination, while other 50% just receive a simple geometric. Because I believe that the distant vision is most important.
Yes.
Don't want any compromise on that.
Yes.
And if the near vision is already taken care of, I would like to go ahead and implant a geometry.
Yes.
The good thing about this lens is the add power in both these lenses is exactly the same. It's only 3.5, but 3.5 and 1.75, but it is only the light distribution based which it plays around with. And I think it's a unique feature of this lens. I don't think any other platform has this feature.
Sir, that was a very well managed case, but in the end you were telling you are not happy with the IOL. Was it the centration?
Sorry?
You were not happy with the IOL?
No, Ellen, the thing is, I am used to having my Baryon right of my objective. Here I had to see the monitor and center this thing. So I was having a little difficulty, and the patient at that point of time, though she was very nice and cooperative right through, was a little uncooperative. So I had a little difficulty in positioning the lens, and I would have preferred even better positioning of the lens, but I think since the boss Srigare said it's quite all right, he'll handle it afterwards.
Okay.
It's not okay.
Any other question from the audience? Yes.
Can you hear me, sir? Can you hear me?
Yeah.
In this case, when we experience such amount of chemosis, will that Callisto system still be accurate, or we could see it varying much? Or let's say if you do a femtolaser, there is extensive subconjunctival hemorrhage also. Is the overlaying method still reliable when you have chemosis?
But, once the image has been acquired, what you say is a relevant point.
Yes.
Whether it's the Varion or the Callisto, it's the conjunctival vessels that matter quite a bit, even more than the iris features alone. But once the image has been acquired, then most often the centration is quite all right. I have never seen this chemosis making it more difficult. In case it had increased beyond, it was becoming a little obvious, I would have just created a small slit and let the fluid out. But since it happened towards the end of the surgery, I did not really want to do that.